Hello, everyone, and welcome to another Unfiltered podcast. You've got myself, Sherry Teague, and Cindy Kraft. We're the owners of K&K Healthcare Solutions. And as you know, if you've listened to any of our other podcasts, especially the Unfiltered varieties, we get onto these podcasts because we have a point to make, or we have a gripe, or we have something that we just have to get off of our chest. This particular one was really interesting because it was another one we had to give it a 24-hour buffer. And for a couple of reasons, because this one involves AI, innovations, and the completion of the Start of Care OASIS document. Cindy and I went to NOC a couple years ago in Missouri, and we happened to meet an individual random. And they mentioned to us that they had 12 nurses that were in the office that were reviewing every OASIS and actually completing the OASIS that the clinicians were performing. And we immediately got off guard, right? Cindy, we were like, you're doing who? You're doing what? And the article that we read recently kind of reiterated that, of having someone in the back office completing the OASIS, but it added a statement about the clinicians not needing to know how to do the OASIS, that they're not capable of being fluent in the OASIS, of capable of understanding it, and why bother? It was kind of that attitude in the statement that was made. And immediately I went, why bother? These are mostly doctored professions. Are you kidding me? These people take care of people. They have people's lives in their hand. Are you kidding me? They can't be trusted with a document that's really kind of a simple document with a simple set of rules. I immediately got very defensive, and and Cindy, I sent it to Cindy right away and said, "Oh my God, this is unfiltered. This is unfiltered material. We got to do this." And we decided to wait 24 hours because we're less passionate and a little clearer. First of all, I'm going to say this: K&K is all about innovation. We are all about getting to the most efficient, accurate way of competing documentation. What we're not about is bending the corners on the box of compliance into a circle to fit some arbitrary new idea that's going to speed up documentation and set aside the clinician. That is something that really makes our blood boil a bit, because the clinician is the one that's sitting in front of that individual and making those life and death decisions often, definitely quality of life decisions, right, Cindy? And at the end of the day, the clinician is responsible. So Cindy, tell me a little bit about what you think about this concept.
You know, to read, to kind of mirror what you said, to have it portrayed that clinicians were basically not able to understand how sophisticated the guidance is. It just gave me pause, because we have for decades, literal decades of my life, said the guidance was written for the frontline clinician. Right. The guidance was written for that data collector, so that they knew what the options were, what the definitions were, and could choose the best possible response. To me, this is the next level of the whole, it's too mysterious, you can't understand it, you have to go to a special class, you then have to get special letters, then we have to have a little special club of people that know more than the clinician. No one knows more than the clinician, because they're actually out there with the patient. The issue is, all OASIS ever has been is discipline neutral data collection. You have basically multiple choice questions, and they give you what those response options are intended to mean, and you pick the best from what you have. I think what's frustrated clinicians for so long is they try to make it a clinical document. They think it's about nursing issues or the functional stuff or therapy questions. Those don't exist. They strictly are data points. They capture incomplete information from a clinical perspective. It doesn't say why the person can't manage their medications, why they're having trouble getting to and from the toilet. CMS leaves all of that to the skill level of those individuals to figure out the why, to do something about it. But to say that someone who's hooking up IVs and making decisions that could literally end someone's life if they're wrong is basically too stupid to figure out how to fill out an OASIS is insulting. I'm sorry. I get it. The technology is there to enhance this. I fully support that there could be better ways to gather information. I mean, I've been in this space so long, Sherry. You remember when we had to do OASIS on paper with pencils and have to, pens, filling things in, turning things in, lugging the guidance manual.
It was an eighth of an inch.
And the guidance manual was what?
Yeah.
Yeah, and Brian's manual was ginormous because you had to slaughter half a forest to print it out and drag it around with you. There were clear obstacles then. But when we first went to EMRs, we were told it's going to make you faster. It didn't. Ultimately, it didn't. They don't say that anymore. It has a lot of positive things. Things are legible. I can access medical records differently and all of that. But it's a tool. It's a tool in the hands of the clinician. So is collecting that OASIS information. And what scares me the most about this, take it out of their hands, just have them review. I think the clinician loses sight of the fact that ultimately this documentation has only one name attached to it. Exactly. And it's my name as the one who completed the assessment, and by extension, my license. So if anything goes sideways with this patient, and that documentation has to be looked at, OASIS, any other piece of documentation, it will be me and only me in that hot seat because my name is on it. You don't have an OASIS co-signed by half of the QA department. You aren't going to have the OASIS co-signed by the EMR it ran through. You're signing that thing. And I think the danger is a combination of clinicians who have been led to believe it's too hard, it's too difficult, I hate it, so I only do it when you make me. Oh, now you're giving me these other paths. The path of you have QA people that make all these corrections for me, and all I have to do is agree. I don't even have to really read the correction. I'm just agreeing, so we show that I was involved. Oh, there's this other technology. I can do voice to text. That way I don't have to type out my narratives. And don't bother to reread the things in it that we see when we audit charts that go, you literally screamed at your dog, didn't you? In the middle of dictating this, it's still here. You didn't even go back and take it out. Are you not owning that these are nothing but tools and you're ultimately responsible? So if I am in a situation where we're using technology to pull some of this information for me, I ultimately have to know I have to go back and review it. I have to own it. I have to confirm it. You cannot cut the clinician out. And there's a risk with clinicians just arbitrarily agreeing and not taking that seriously. And those things could collide in very nasty ways in the future.
And we're hearing that these phone calls that are occurring between the frontline clinician with this person that's putting the data into the OASIS, we're hearing them be very brief. I think this particular article said 12 minutes. We heard 15 minutes. And Cindy and I both kind of went, that's curious that an 18-page document could be discussed thoroughly enough in that period of time to get it completed accurately. And I understand that there are people in your clinic right now that understand the OASIS more than this. You know, one clinician compared to the next, one's going to understand it longer because maybe they were there during the pilot project. Maybe they love it like Cindy Kraft crazily does, and they just are interested and intrigued by what it does. It literally tells the government what's going on in patients' homes, and I don't know that someone sitting in an office can accurately reflect that. It's the leaky bucket. It's the telephone game, if you will. We all played it in elementary school, right? Where we had a concept that went through the room, and by the time it got to the end of the room, it didn't even resemble what it started as. And so I think that there's some pearls of wisdom in some of these ideas, but I think that they're off the mark on what they're shooting for to make it more efficient and more appropriate for the clinician. Cindy, other than taking over the data collection and the observatory encounter, interview / functional, get them up and move questions, what are some things that could help clinicians even more and stay firmly within the guardrails of compliance? What do you think a home health clinician is looking for?
Well, before we go there, I want to touch on that 12-minute thing, because you can't tell me that the time savings is the clinician basically reciting what the response options should be, because it would make no sense to be reading over the phone your BIM scores, your other scores. So I have a suspicion, and I could be very wrong, but what this really is about is gathering information for certain sections of the OASIS, and most likely functional assessment related, outcome related, payment related. And you and I have spent hours of our lives arguing there aren't questions that are more important than other questions. Think about risk adjustment. That whole tool comes into play as they look at how they assess our data. So picking and choosing about what we're going to focus on can lead to problems, which is a whole other conversation about GGs and how they're just GGs and suddenly now they're not. But although data points matter. To me, the tip for the clinician, honestly, what I really wish we could do, Sherry, is that device from the movie Men in Black. Remember when they would hold it up to people and clear off? I actually have one. I found the one that I got at an amusement park in Florida when we moved. Because I got one physically because I wanted to be able to just pretend I could use it. But if we had that, what I really wish we could do is wipe the slate for clinicians about the negativity of OASIS. Mm-hmm. It's hard. It's this, I'm not ever delusional enough to say they're going to be, excited about OASIS and want to fight each other for starts of care. But I think we have structurally as an industry fed into it's too hard for you. It's difficult. It's time consuming. Let me take it off your plate. We need to empower clinicians. Here's the instructions. And overwhelmingly now, I don't have to go kill trees and drag around this giant book. I can click on things. I can click on things within my EMR right at the question that will give me the guidance that I would want to consider when choosing a response. If it's not that, I can have an icon on my computer that is the most current version of the guidance manual in PDF form and search it by item number. I don't even have to rifle through it. It'll take me where I need to go. It's teaching, the infamous teaching them to fish. Yes. The guidance is there for you. Look at it. And we're so thankful there isn't the OASIS of the month, okay? Instructions tend to be stable for extended periods of time. So I don't need to look up every question every time. I'll find my groove. But by doing that, I also decrease the correction issue. I don't have to wait for this to go through QA and come back with mistakes, because I'm confident I've picked the best possible answers, and mistakes should be an anomaly. So when we're talking about saving time, my time spent having to deal with QA sending it back, yes, we hear that if you call somebody, you cut that down, but not really, because I still have to review that work. I think clinicians need to understand and embrace this opportunity in terms of discipline neutral data collection. I am providing data points because I have a concern bigger than what we tend to see as the short-term gain. Okay, less time spent on a start of care. The QA process is faster. We're confident that the answers are where they need to be. Yay, you. But it's called the outcome assessment information set. Outcome measures are a critical part of this tool. And yeah, okay, we had them call in again at discharge, and then that part is right. But what you've done is you've not only further disengaged the clinician tasked with filling it out, then how important is OASIS to the LPN, the PTA, the OTA, the home health aide, the social worker, people that currently cannot fill one out at all, but the decisions that they make on each and every visit make or break your outcome potential.
Yep.
So this whole, let me take it away, it's too hard for you to understand to fill it out. Is the care team understanding it well enough to deliver care with an eye toward, all right, this is what the measurement is. How are we moving the patient from this point to this point? How are we utilizing this information? And looking ahead to the pivot to GGs in value-based purchasing, this isn't just about who filled out the form right. Those care decisions in between are vitally important. And I'm concerned that this technology as a short-term fix for a complaining clinician who thinks this is a lot of work to do just means, wow, I made a phone call, or AI did this, I just signed it, and I just go about my merry way, I'm done with it. We're never done with OASIS. We're not supposed to be done with it at that time point. It is what are we doing in between that matters. And that's the piece that I am even more concerned about with this technology, because if we disengage more and more of that care team from the process, or even a basic understanding of what the measurements are, then we can sit there at discharge and say, but they didn't change, they didn't get any better, or they got worse, and why weren't we focusing on this? Maybe because you took it out of their hands from the very beginning.
And I also want to interject a little bit of agency ownership. When I owned an agency, I was often concerned about how much FTE I was giving to a problem? How many full-time equivalents was it going to take to solve a problem? And it concerns me that let's use the 12-minute thing because that's sticking in my head right now. That's 20% of an FTE. 12 minutes is 20% of an hour. Okay. And how are you paying for the clinician's hour and that 0.2 hour that's sitting in the office and doing multiple of those? Where is that money coming out? Because you're spending more money actually completing the OASIS document. So that leads me to the possibility that the answers are being massaged in a way that would improve reimbursement. Red light siren, guys, red light siren. That is what we have been accused of as an industry from the time the OASIS came out, that it has been gamed, that it has been massaged, that it has been tweaked just enough to get into certain risk categories or to get into certain reimbursement buckets now with the PDGM circuit. Cindy, that to me is so risky to innovate when there are so many other areas that we can address to take some of the heat off the clinicians. And we have a friend who sadly has passed, may she rest in peace. And every single time we were ever on a call with her through the APTA or other national associations, we could guarantee we were going to hear this word. Why do I have to call the physician for an order from the start of care? Why is that necessary? Why can't admin take care of that? And we used to say to her, you're a clinician, that's your responsibility. But Cindy, talk to me about innovations around that process. Well, and as we're kind of wrapping up, I'm going to let you close us out with that, because to me, that's where the efficiencies can happen. That's where the increased compliance can happen versus the possibility of the decrease. So go ahead, Cindy. I'm going to let you have this one.
But I think it's looking at that bigger picture as a clinician. So yeah, okay, I don't like doing paperwork. I understand that. But I cannot say I'm a wonderful clinician and I screw up the OASIS all the time. No, my documentation is my responsibility and is an equal partner in delivering high quality care. Yes. But if you're talking about taking things off my plate to make me more efficient, calling the doctor for orders, and then having to leave messages, and then they call me back while I'm in the middle of the next visit. So I miss that and I can't get that. Why would we not say, as opposed to further babysitting the OASIS, let's teach, train, and empower you to do it. And let's have that office person be the one I call, listen, we need orders for this, because the order isn't for me personally. It's for the patient, specific to their needs, may involve a discipline or whatever. I call, following all state rules about who can get orders, and that person track down that order. Get that order, take care of that order, be on the phone for that order, get the call back on that order, because you're in the office, you're not going to run to the next patient's house. And then you track that order in real time as quickly as possible and notify me when it comes back. Because what we see in these discussions about innovation is all of these challenges of the clinician. Yes, but we don't have to just say, if I made OASIS easier for you, then you'd have all this surplus time. Really? Because the interruptions are things around orders, are things around scheduling. And even there, that's a whole other, maybe other podcast. You know, I've talked to individuals and agencies whose solution is, we took scheduling completely out of the hands of the clinician. Isn't that great of us? And then you talk to the clinician who goes, I have no idea where I'm going any given day. It's somebody in the office moving things around on the board. And I had a patient, this patient went away because they gave him to somebody else. So sometimes these take it out of my hands. We can do better in a hybrid model. What are those pieces that an office-based person could do? And when is the last time when we come up with these solutions, we sat down and talked to clinicians and said, what would make it better for you? What would make it easier for you? Not what solution can I make because I think you're too dumb to do this, right? But right. What do you need? What can they come up with? What are their ideas? So, you know, and just thinking about innovation, that issue of orders, I think to our friend's point, the whole, why do I have to call? Yes, if I found something urgently in the home, I'm going to call. But if I can't get through, somebody's got to call back. We got to have all this back and forth. Is there a better way to do that would make my life easier and I can focus more on the assessment of this patient and focused good, not necessarily more, good intentional documentation. And then a lot of this stuff that blows out in ADRs and TPE, everything else could simply be avoided if we understood what the power is and what the knowledge level is of that frontline clinician. Again, I don't believe you can say I'm a wonderful clinician, but I don't understand qualifying criteria. I don't really understand homebound status and don't document it well. My OASIS is highly suspect and has to go through corrections 5 times. All of that needs to be addressed by empowering a clinician. I don't believe it's in belittling them or just taking things away from them and saying, you just can't handle this.
And Cindy, this would be a great business model for you and I. We do a lot of outsourced reviews of OASIS items. So if we weren't the people we are, we could say, oh, opportunity. We could just start completing OASIS for agencies. That you guys is just so scary, because ultimately a policy or a procedure in a home health agency is not going to be sitting on the stand talking to the ALJ or talking to a judge or an attorney. They're not. It's going to be you. It's going to be you who signed your name to that document. You have the final say when it comes to that OASIS. And that was the other thing that was missing from what we've been reading, is we never see that it returns to the clinician for approval. That's still in the COP.
Or it's just kind of, it goes back to them and they look at it. And it's like, but are you encouraging them to really look at it, or just rubber stamp it to expedite it to agree with you? Because
is that kind of what they're counting on, though, Cindy?
I do, because when we talk to agencies and they're like, our clinicians are wonderful, they never, ever push back on OASIS corrections. And I'm like, never? Then my next question is, do they keep making the same mistakes?
Exactly.
Then there's silence. Apathy of disagreement.
Ongoing mistakes is expensive. So,
right. But apathy and agreement meets the technicality of the rule. But a clinician, even in that situation, needs to know you do need to look at it. We expect you to look at it. And if you have different opinions than this, then we need to have that conversation and not just kind of feed on the you'll just agree and we can just make this move faster.
And again, I'm going to close with K&K loves innovation. K&K has had the privilege of being on calls where people are demonstrating their AI solutions in home health. They're not there yet. They're not there yet with the accuracy of those solutions. We've not seen one yet that pulls the correct information out of a medical record document. They miss some of the nuances, kind of like some of the scrubbers that are out there that miss some of the nuances. But I think it's super clear. Our plea right now is to the clinicians, to the nurses, the therapists, anybody who's filling out that document and putting their name on it, whether you're filling it out or not, because apparently there's some that aren't filling it out. But if you're putting your name on that document, you're sealing that as your decision. And that's not something that you want to take lightly. And so if we can end with one thing, that would be the thing that I would hope would come out of this. First of all, you passed kinesiology. You passed how to do IVs and how to calculate all the things for the ratios and all that stuff as a nurse. You passed gross anatomy, where you had to learn every piece of the human body. You can handle the OASIS.
Yep.
Period. You can handle that. Mm-hmm. Will you get it accurate 100% of the time? No, because there's little nuances here and there about what's continuous oxygen, what's not continuous oxygen, what's a proxy, what's not a proxy. That can be brought out as it comes up. And I think that we just need to make sure that everybody knows that that's ultimately their responsibility. Do you have any final thoughts, Cindy?
No, I think that our passion on this subject has come through in this particular Unfiltered. And if we kind of irritated some people, we don't deliberately intend to do that, but we rather have good conversations about these issues and get people to think and not just be, the technology is going to save us and be this magical solution and we never have to pay attention to this stuff anymore. We just want people to be careful and to not lose sight of the patient and the clinician in all of these discussions, because at the end of the day, that encounter is what home care is. And we want to make sure that that is preserved, that is accurately reflected, and that we honor it and not make it, well, we have to always puppeteer it from everywhere else because they just can't possibly understand. Did we really ever explain it right to begin with? So I appreciate our energy sharing. I know we tried to keep a time on this one and we went a little bit longer, but if anybody has any thoughts about this topic and wants to reach out, we welcome the conversation.
Absolutely. We would love to have feedback on this and anything that maybe you've worked out, that you've come up with this great idea that falls within the realms of that compliance. That would be a wonderful thing to hear, because I think it would help everybody. So thank you, Cindy.
One last thing. And if you have an innovative idea and we want to talk about that, we have had people end up being on one of our discussions because of that. So don't be shy. If you have this great idea that you want to share, please let us know.
Absolutely. Thank you again, Cindy, and thank you for everybody who listens, and be safe out there.